All right, so it is my 5th week of my neurology rotation, and I'm actually on PM&R this week. So we get one of our neurology weeks as, something that is not really the field of neurology, but kind of related. PM&R, or physical medicine and rehabilitation. I've been looking forward to this week for a really long time, honestly, before I even started rotations, primarily because I am pretty interested in PM&R, always have been since I've discovered that it was a field. I don't really have a lot of experience with it, but I do know that they deal a lot with the musculoskeletal and nervous system, and those are two of my favorite organ systems in the body, so I just kind of have an idea that I might like the specialty. So PM&R is a field that not a lot of people know about in terms of like the general population, but also in terms of medical students. I would assume the vast majority of med students don't know what the field is before getting to med school, and honestly, it might take until like your 3rd or 4th year where you're actually in the hospital to learn what it is. Sometimes on IM, we would see patients have, a PM&R consult, but other than that, like we didn't really have a lot of in-depth exposure to it, which I think it's cool that everyone that goes through our core rotations has to do a PM&R week. I would assume at most other schools, that's not the case. It's one of those fields where it's a little bit more niche, so you might not get any experience with it until you're doing your electives, like in your late 3rd year or 4th year. So in terms of what PM&R is, I will read the official definition from the American Academy of PM&R. Physical medicine and rehabilitation, also known as physiatry or rehabilitation medicine, aims to enhance and restore functional ability and quality of life to those with physical impairments or disabilities affecting the brain, spinal cord, nerves, bones, joints, ligaments, muscles, and tendons. So like I said, they deal a lot with the nervous system and musculoskeletal system. In terms of what we're going to be doing this week, our whole week is in our inpatient rehabilitation unit. So basically, it's a sort of area for patients who are not sick enough to still be admitted in the hospital, but also not healthy or strong enough to go home or back where they live. So they come to us and we help to get them a little bit healthier and stronger and more independent. So once we leave, everyone is confident that they're going to be okay. And while we haven't had a lot of like hands-on experience with inpatient rehab, I do remember on my internal medicine rotation, there were so many patients where we would recommend that instead of being discharged right to home, they go to a rehab first so they can get a little bit stronger. So now it's going to be nice because I'm actually going to see what happens when a patient is discharged to rehab. All right, so it is Wednesday and I just got back from the hospital. First off, one really nice thing about this week is I don't have to get there until 9, which is a lot later than many of the other rotations that I've been on. So I have plenty of time to sleep in a little bit, go get a workout in, and then head to the hospital. So it's just been a really nice change of pace because even on the neurology rotation, usually we have to get there at 7. But in terms of how the work is when we're actually there, sort of the general workflow is we'll get there around 9, we'll be assigned a patient or two from our resident, and we will sort of see them independently. First, we'll chart check, see if anything is updated, and then we'll go see them. The other good thing is we tend to follow patients, for multiple days, which I did a lot of back in IM. Like if you got a patient on Monday and they didn't leave till Friday, you just saw them the whole week, and you would add on a few more patients here and there. But for whatever reason, for neuro, they don't really do that. We will just have a completely new patient every single day, even if the patient you saw yesterday is still on your team. I think it's just so you can get a lot of reps in of doing a thorough chart check on the patient to figure out what is going on and do sort of your initial interview skills. So on one hand, I understand that, but it's also nice to get like the longitudinal aspect and see how a patient progresses over the week. And that's like really important for the inpatient rehab because you're trying to see how they're improving to see if they can go home. So yeah, we've been following sort of the same patients every single day, and then maybe around like 11 or 12, we'll run the list with the attending. The attending we're with this week, he doesn't really like to round with the residents or students. Everyone just kind of does their own thing independently, and then we come together to talk about them. Then we'll grab lunch, maybe there'll be a lecture or something for noon conference, and then in the afternoon we're just kind of waiting around to see if there's any consults. It's kind of interesting because sometimes the consults will come from sort of the hospital that we're attached to / associated with, but a lot of the times there's patients who are coming in from outside hospitals too. So that's something that I haven't really experienced yet on any of the other rotations. It's actually kind of crazy. This inpatient rehabs has 5 different teams. So we're just on sort of the general unit, but then there's also TBI or traumatic brain injury, there's spinal cord injury, there's like cardiac pulmonary rehab, and then I think there's a team just for like the neurocritical care unit. So there's a whole bunch of residents here, really great program to be at, honestly. As the general PM&R team, we've been getting a lot of like post-op patients. So I've been following some ortho patients this week. There's vascular patients, patients who've had brain surgery, and then there's also some patients who were admitted for stuff like pneumonia or UTIs and are just a little bit too weak to be able to go home right now. One cool thing that I experienced today actually was while there is the inpatient side that we mostly work in, the attending also does outpatient stuff. So there is sort of a separate part of our building that is just for outpatients. And, you know, a few times throughout the day, he'll have outpatient injections come in. So we've been able to see a few of those. And these injections he does, it's actually Botox injections for spasticity. So spasticity is sort of a muscle rigidity that can happen after any sort of nerve injury, usually strokes. I think those are the 3 patients that I've seen so far. It's all been after a stroke. And basically their muscles are just like a little bit too tight and it affects their function. So you use Botox to sort of paralyze or loosen up those muscles so they can move them better. And it's actually very cool how they do it. They use EMG, I guess, to guide the injections, because sometimes if you're like injecting for something in the hand or wrist, there's so many different muscles here that do slightly different things, and it's hard to know exactly which one you're targeting without using EMG. So EMG is like an electrical technology, I guess, that measures muscle activity. So the way that they do these injections is the syringe with the Botox in it, and then they have the needle, which is hooked up to an EMG machine. And, you know, once they put it in the muscle, they either passively move the joint or they tell the patient to do a certain movement, whether it's like flex or extend the wrists, you know, make a fist, that kind of stuff. And then they can sort of hear the electrical activity of the muscle with the EMG machine. So then they know if they're in the right muscle or not based on if it gets louder or quieter. That's sort of a vast oversimplification, but I don't want to be talking for too long about that. But basically, it's just a way that they can make sure that they're in the muscle that they want to be in. And then they inject the Botox. The procedure lasts maybe like 20 or 30 minutes, and then the patient comes back in like 4 to 6 weeks for them to check up. You know, that is kind of when they'll start to get the maximum effect from the Botox, so they'll be able to see if it worked or not, see if they need to get any more, or sort of guide treatment for the future, because unfortunately it does wear off in like 3 or 4 months, and then a patient would have to come back and get it done again. But then they'll be able to sort of look at the improvement they got and sort of make adjustments for the next treatment. All right, so it is Saturday. Just wanted to wrap up how the rest of the week went. So Thursday and Friday, very similar to the first 2 days. Got there around 9. saw the patients that I had been following, rounded with the team, and then got to go home around like 3. So all in all, have been pretty chill days. One cool thing I was able to do towards the end of the week was actually go to one of my patients' PT sessions. So I guess I haven't really covered this specifically, but the whole point of the inpatient rehab setting is to get patients feeling stronger, healthier, so they can leave the hospital and go back home. And the sort of best way to do that is with various kinds of therapy, mostly physical therapy and occupational therapy. Physical therapy more so focused on larger muscle groups, really trying to train them with walking, using stairs, that kind of stuff. And then occupational therapy. And then with occupational therapy, more of their sort of activities of daily living. So making sure they can write, dress themselves, that kind of stuff. Also, sometimes patients will need like pulmonary or cardiotherapy, which is sort of like a graded exercise program. Some patients will need speech therapy, especially patients who are post-stroke. So the cool thing about this is there's this huge team of people, and they all kind of have their role and their specialty, but they're all working together to restore function for the patient. And Thursday, we actually had like a team rounds, which I think does happen on other specialties, but you don't really see it happen, or like the doctors don't really go. A lot of the times it's mostly like PTOT and like the nursing staff. But we all got together in this room. It was the attending, the resident on our team, me and one of the other students. They had nursing there, I think case management, and then PTOT, and then speech if it was relevant. And then we just went through all of our attending's patients, and everyone sort of said their piece of, from a medical point of view, this is where they're at, this is what we need to adjust, then PTOT, all that, and then they're kind of just coming up with a plan, trying to get a discharge date. It's really important for PM&R because the physician is really like the captain of the ship, and they need to hear all of the input from PTOT. They really need to understand how they're doing before they can make any decisions of when they can go home. And since the physical therapists, occupational therapists see them sometimes multiple times every single day, and they're seeing their progression, they're sort of the best people to go to in terms of knowing their current status, what they need, and how they're gonna get there. I did talk to our resident that we've been working with this whole week about the breakdown of her residency. And PM&R is a 4-year residency where the first year usually isn't PM&R at all. It's a sort of transitional or preliminary year. Usually you'll do your intern year in IM, and then the actual PM&R residency starts as a PGY2. So she's a PGY2, and she was saying how at least her program, your second year, you're pretty much only doing inpatient stuff. So as I mentioned earlier in the video, there's like 5 of the different inpatient teams, so they just rotate between that every single month. And then in your 3rd and 4th year, that's when you do a lot of your outpatient stuff and get to do different electives. There's so many different fields that you can go into through PM&R. It's such a broad field, and you can do fellowships in traumatic brain injury, spinal cord, you do pain management, pediatrics. It's a way to get into non-operative sports medicine. You can do a cardiopulmonary fellowship, and you can actually work with prosthetics and orthotics, so people who are amputees. So overall, I did really enjoy this week. I would be interested to see more of the outpatient setting just because I prefer that, and sort of the most exciting things that we did all week were those outpatient Botox injections. But yeah, at this point, I would say PM&R is probably at the top of the list for like a non-surgical specialty.